overall, we're getting to the impact of racism on health, okay? And there are different ways that we can talk about that, and I'm going to consider it in this presentation. Additionally, Laura mentioned that I am currently teaching at the University of Connecticut, and I also have a nonprofit called Cheer Institute. My area of research is grounded in racism and health outcomes, and I look at this from a sociological and also a public health perspective. So the objectives for today are consistent. So I want to define health inequities. I also want to describe various pathways from racism to adverse health, and also to explain how multiplicative impacts of racism really exacerbate adverse health outcomes. And my research is mostly grounded in Black African American populations. So you're going to hear me referring to Black African American or people of African descent often in this conversation. And the reason for that is because that's where most of my research is based. So I do want to kind of start with just a schematic of social determinants of health. This is probably something that you've seen probably ad nauseum, but I do want to place it here though too, just to kind of ground us in our conversation. We're talking about health disparities, we're talking about health outcomes. We have to consider the various ways in which we appreciate and understand health, right? So health is much more than the physical outcomes, whether it be if we're talking about obesity, if we're talking about health behavior, if we're talking about a mental health diagnosis, say, bipolar, if we're talking about cancer rates or HIV, etc., we have to consider health within the context. And that's always important for us to ground ourselves. And the social determinants of health, and I'll go into a slide, the next slide speaks to this as well. When we consider these social factors in these various ways that health is grounded in the social systems and the social structure, we actually get to at least one level of accountability, referring to policy. Okay, and I do like to situate us there because we have to be thinking about the kind of changes that we want to see as we have a conversation like this. Furthermore, and I think this is equally important, is if these are factors that are very much tied to health, economic stability, neighborhood and physical environment, education, food, community and social context, and the healthcare system. And you could read underneath each examples of those different indicators. If, if we're seeing different social outcomes in terms of accessibility to these various factors, we're very much going to see differences in terms of health outcomes. So when we're talking about health outcomes and we're talking about race, but specifically we're getting into racism in terms of that differential treatment, we begin to talk about how people have different access to these various resources. And the big question is why? So this is, a statement again to ground us here, though, too. We're talking about health, and really, as it relates to social inequality, we begin to talk about health injustice, right? Or the call for health justice. And health is perhaps the most sensitive indicator of social injustice. All right. So through health outcomes, we could very well have a good sense of um, inequities, and I'm going to say more than disparities, but inequities in terms of housing, inequities in terms of income, inequities in terms of education, okay, inequities in terms of healthcare access for various reasons. So when people are fighting and protesting and really when there are various calls for action in terms of the need for health justice. We're talking about people really fighting for and trying to, in many ways, remedy the toll that social inequities have taken on our health. Okay. And I want to move into specifically racism and discrimination. Okay. So experiences of racism, discrimination broadly, okay, but racism specifically, whether it be at work, whether it be when a parent shows up to their child's school, whether it be in the community, right? Or even in consumerism when people are just, shopping. Um, but in everyday social experiences that people have, okay? if someone is or a child is trying to just get home to their family, there's a toll that it takes. Okay. And we have to be able to measure that toll because we are seeing extreme differences in terms of health outcomes in populations based on race. So health disparities by race, and I have health disparities by gender. This timeline's a little dated, okay? It's from 2000 to about 2011, but we see a consistent pattern. These patterns have not changed much, all right? One pattern that I will note, and this is important for everyone across the board, since COVID in this country, we see that we've seen a decline in life expectancy. And this is actually one of the it's probably over a 50-year period, we saw a huge decline in life expectancy due to COVID. And again, we're looking at population level. Okay, that's important. But what we see here, though, too, even if with this 11-year period, even though it's going back 13 years, we're seeing a consistent pattern and trend in this table. The consistent pattern and trend speaks to basically how long people are living based on their race, based on their gender. And the overall pattern is that what we're seeing here is that we're seeing that consistently Black people, Black men and women live shorter lives, okay, and are expected to live shorter lives than their white counterparts. Okay, that's broadly. And then as we tear down into this a bit more, we see that Black men live considerably shorter lives than white women. Okay, so we consistently see those two patterns. And then we have to ask other questions. Why do we see this difference in terms of health outcomes? What are the social drivers, going back to the social determinants of health, that are significant in terms of the various health outcomes that we see across population groups? So, leading causes of death for African Americans, heart disease at the very top, cancer, unintentional injury, stroke, homicide, diabetes, chronic lower respiratory disease, kidney disease, HIV, septicemia. And this is there's some changes here though too. One, we're seeing an increase and if we were to look specifically by gender, okay, look at Black men, for example, we would see other variables as well. Maybe increasing rates of suicide would be noted on a leading causes of death. We also, due to the COVID pandemic, we also saw an increase in other respiratory conditions as well. Respiratory conditions are noted here, but this is can be altered a bit though too. So the history of health disparities. So the language of health disparities is not that old. However, the work of health disparities, noting differences by race, okay, or differences by class or differences by gender, that work is not new. Okay, so this goes back very early, right? So, and I would say in terms of public health, and this is not the earliest time, but we see scholars, public health professionals, we see sociologists. I think of the work of W.B. Du Bois, okay, really looking at studying the health outcomes of freed slaves, right? And also Black people in, say, the Philadelphia study. In terms of Black people, Black populations based on class. But prior to that, though, too, kind of looking at the outcomes based on social status. If we consider again the correlation between race and also social status, right? But in terms of the documentation of health disparities, we see that term being used in the 1990s. And we saw early references in an intentional um, attempt to really document some of the differences and to really understand this differently with the Malone Heckler Report in 1985. And there was a special task force on Black and minority health. And that data, though, just described this huge gap in health status between African American and whites. Now, certainly not the first time, but it was documented with an intention for policy outcomes. Um, a similar report for other groups was not possible due to lack of data. So, specifically in terms of Asian American populations and Indigenous populations, for example. But since that time, the term has been widely used. And I want to also offer another caveat. In certain public health spaces, people won't say, although, or I should say, they will use the language of health disparities carefully, okay? Because health disparities generally notes differences. right? But when we get into, or if we're using a social justice perspective, it may then be more important to speak of health inequities, right? And health inequities, then we speak to um, outcomes that are unjust and that are unfair and essentially are preventable. So going back again to the social determinants of health, if we're talking about health outcomes that are due to those factors, income, education, health access, neighborhood safety, social engagement, right? Those are factors that can be changed. Those are social conditions. Okay. So when we speak about health inequities, it may, or the language or the differences that we're seeing, it may be more appropriate, okay, to speak about them in terms of health inequities because they are injustices that can be corrected. So more about African American health disparities or injustices. So African Americans can expect to live 3.5 years less than their white counterparts. For Black men, this age gap is even larger. Okay, so to 6.5 years, I did mention before that life expectancy actually declined across population, US population due to COVID. With African Americans, infant mortality rate is 2 times greater than non-Hispanic whites, and infant mortality is a significant indicator of the health of population, okay, and also speaks to access. It speaks to whether it be healthcare access and other social services, but we're seeing a lot more research, a lot more conversation around medical care, care and treatment, okay, bias in healthcare as it relates to infant mortality and maternal deaths. Infants, Black infants, are 3.5 times as likely to die due to low birth weight. And this, the rates continue in terms of morbidity and mortality. So in 2020, African Americans were twice as likely, more than twice as likely to die from COVID than their white counterparts. In children, we see rates of asthma and deaths from asthma 10 times that of white children. Okay. And we see that African Americans have the highest rate of any other racial group in terms of mortality from cancer. And that language is specific, not morbidity, not rates of getting cancer, but deaths from cancer. Okay, so this is there's something that's happening here. So we're seeing we see probably higher rates in white populations. So if we take breast cancer, for example, with Black women and white women, okay, white women get or are more likely to be diagnosed with breast cancer than Black women, but we see Black women dying from breast cancer more often. Okay. Again, that is an inequity. African Americans are almost twice as likely to be diagnosed with diabetes as non Hispanic whites. We're seeing higher rates of blood pressure, 40% higher. We see higher rates of HIV as well. This is another chart that I like, and I usually like to kind of lay this one over social determinants of health. This one really gets into it, shows implications for policy. Okay, and it starts with the actually, I'm going to first point or bring our attention to this kind of pink orange box here, and it speaks of socioeconomic position and social class, and really narrowing in here on the socio-demographics. Okay, so gender, sexuality, ethnicity, or race. Okay, but for this, we should be thinking about discrimination. Okay, how people are actually treated, how people experience their social situation based on, how their gender is perceived, how their sexuality is perceived, how their race, ethnicity is perceived. Okay. And furthermore, we have class and educate. All this is class in terms of income, education, occupation, right? All these class variables, how their class is perceived. That happens within the context of these broader social implications, the yellow box over here. And we call these social political contexts. So in terms of how people are able to access jobs with the labor market, how people are able to access the educational system, social policies around health and healthcare, also culture, religion, human rights, and human justice, how they protect people or don't. Okay, so all of these things around health are happening within a social political context. But what we see in terms of what this um, schematic is showing us. We have this larger social political context that there's a two-way relationship in terms of how it impacts the experiences that people have, right? And even how policies are really sometimes directed at certain populations, right? So that people don't get equitable treatment. But all of these collectively lead to various factors that will impact health, right? So, in terms of material circumstances, housing, in terms of access to work, in terms of access to food, those social determinants of health that I shared previously, in terms of psychosocial factors, supports, care, help seeking behavior, right? Health behaviors, other biological factors, and what that means. For example, is someone living in an environment that is going to lead to higher rates of, say, asthma, right? Or environments that are obesogenic, right? That are more likely to cause higher rates of obesity. All of these factors collectively, individually, and then the collective impact can lead to sickness and disability. All right. And then we see, again, a huge impact on health overall. So I just wanted to point out that particular table. So let's really lean into racism, all right? And really what racism is and how it shapes the experiences that people have. And then I want to go into how racism impacts health. So racism, and first of all, in terms of defining it, I don't think that I have a very direct definition in this slide deck. I should. When we're talking about racism, we're talking about really a system that impacts how people are treated in terms of access to resources. Okay. And this is really based on race. So we're talking about a system of treatment. We're talking about access. We're talking about implications for policies, implications for um, economic factors. And what one piece though too, when I speak about racism, I also like to give there's also a historical context to racism. Okay, and we know that in this country race changes, right? And how people are defined as race and how people are kind of pushed into labels around race. But what we see consistently is the association of treatment based on physical characteristics, right? Or even association with a particular group. So racism is related to various social inequities. Again, going back to that table of social determinants of health, unemployment, poor quality housing, neighborhood and community underdeveloped, crowding, poverty and violence. Um, and those same factors, those social factors have an impact on health. Now, one thing I will say here, though, too, we can get into this at the end, and I will say this from a sociological perspective. There are going to be various sociologists who have different and even kind of there's this still comes up in discussions today, right? In terms of why we see these different outcomes. Now, some people may say, well, maybe people aren't trying hard enough, right? Maybe people are not really intentionally trying to lift themselves up, by the bootstraps, if you will. Maybe people, want to have this particular, experience, right? Now, to that argument, though, too, we have to recognize how when we talk about the outcomes, right, we have to look broadly on who's doing well and who is not, right? And we have to look at the chances that people have, the opportunities that people may be given to do well, and other people may not have those same opportunities and chances. Part of that idea to say that, well, maybe some people are not working hard enough is really ignoring or not being at least it's not as clear in that kind of argument in terms of the different opportunities and really privilege, because privilege is often blind, that people have that others don't. Okay, so that piece needs to be really teased out in terms of that kind of conversation as we really understand racism. So in terms of this research, um, I have here the last decade. I'm actually going to say probably at this point, we're talking about over 20 years, right? At this point, about 20 years, we've seen a body of research that's dedicated to discrimination. Well, discrimination in health, I would say probably 20 years, but I would say in terms of racism about that part. But over the last Let's say probably really, let's talk about COVID, right? The past 5 years, there's been a huge uptick in terms of this focus on racism. Around the time of COVID, racism was declared a public health emergency, right? A public health issue. There was more acknowledgement, but there were scholars in the late 90s, early 2000s who were grappling this, and prior to that, there was more research associated with discrimination. So we're looking at about 20 years. So how do we do this, right? So oftentimes there's some tool that's used in terms of measurement of racism, whether it be perceived or internalized, or other experiences of racism. So I'll go into the definitions of different types of racism in just a bit. But some of this scholarship speaks to the associations with different health outcomes, whether it be heart disease or hypertension, sleep patterns, um, health behavior, right? Food consumption, cancer rates, and substance use disorder. And I'm currently working on a project that focuses on racism and substance use disorder. So conceptualization of racism. So I'm glad I actually do have a slide that speaks to this. So when we're talking about racism, we're talking about beliefs, attitudes, we're talking about institutional arrangements, right? Again, in terms of how our society is structured in such a way that there is advantage for some and disadvantages for others. Also, intentional acts that may devalue individuals or groups because of phenotypic or physical appearance, or ethnic group affiliation. And when we think about acts like this, it could be the media, right? And the media is a social system. If we talk about the media, and there are often subtleties around this, but if we talk about the media, say from 1960s, right, or 1950s, or if we go back even to say 1940s, 1930s, we kind of look at textbooks or even other books that children were given, and we see negative connotations of people of color, specifically Black, African American, Indigenous populations, as well as Asian populations, right? So we see a lot of imagery that is offensive, that's derogatory, right? And that becomes, a lot of the impetus for the attitudes that people have, and hence even the behaviors, right? So the way that I've described it here is we can see racism happening in terms of attitude, racism in terms of behavior. So the attitudinal piece is we're talking about represent attitudes and beliefs that devalue individuals and groups because of how they appear. All right. So it could be, comments about potential comments about even a surprise if someone has attained a certain level of education, or someone's ability to process or to think or to speak in a particular way. Behavioral racism, which speaks to acts that actually deny acts deny access or difference in terms of treatment. This can be violence, right? This could be not being considered for a job because of someone's name, right? It could be other types of bias in terms of care and treatment, or assumptions about what someone, could, whether or not they're able to take a medication, or someone's experience might be in terms of where they may live, and all these other associations because of how they appear. So institutionalized racism, here we're talking again specifically about differential access to goods and services. The important piece here is that institutionalized racism can become normative. Okay, it becomes accepted as normal. It's legalized, it's built into laws and policies, and it's structural, okay, in terms of being systemic, right? So we see here it can manifest in material conditions and in access. So we could talk about police brutality. We could talk even about a history of job promotion, right? So maybe if we're talking about people being promoted based on, say, longevity in position, and say we go back to like the 70s, right? And if we're saying, well, you know what, Jim was promoted to manager, and that should be fair based on Jim's time in. Okay, so he's been here since 1970 in this particular capacity, and we're in 1985, so Jim should be manager. What that ignores is that people of color probably weren't allowed to be in specific positions or in certain roles or in certain organizations at that particular time, right? So that is also institutional. Personal mediated is what we often think about in terms of how an individual treats or views another individual or a group based on physical appearance. There could also be different assumptions about abilities, motives, etc. If a manager decides to hire someone because or decides not to hire someone because their name sounds ethnic. Internalized. That is when a member of a oppressed group or stigmatized race or group actually begins to believe and really integrates these negative ideas about their own capabilities as well as people who look like them. Okay. These are some questions from an everyday racism questionnaire that what might be used in various studies to assess how, say, survey respondents experience racism relative to health outcome. So there may be questions around, how often you're treated with less courtesy than other people. Um, you're treated with less respect than others or receive poor service, or if people assume or think that you're not smart, if people are afraid of you, if people act as if they think you're dishonest, or if they think they're better than you, or if you're called names, or if you're threatened or harassed. This is an everyday racism questionnaire. And the discrimination scale, this could be oftentimes these scales will look at discrimination based on race or based on gender or based on class, right? So if we were taking this, in our context to focus on racism, at any time in your life, if you've been unfairly fired, it would be based on race. Or for unfair reasons, have you ever not been hired for a job based on race, or unfairly denied promotion based on race, right? Or stopped, searched, questioned, or physically threatened or abused by police based on race, or discouraged by a teacher or advisor, or prevented from moving into a certain neighborhood, or moved into a neighborhood where neighbors made your life difficult for you and your family, all these based on race. So, what does this do? Right? When people experience racism, this is really kind of the heart of this talk. What is the impact? Right? What does this do to people? So there are different models that consider this, right? And we have to think about what we call pathways. And I'm really interested in looking at the multiple pathways. And one thing I will say though too is I've become more critical of the research, especially a lot of the new research that says, okay, we have these disparate outcomes between, say, black and white population. We're finding that, you know what, these rates are really significant. Say COVID, for example, in African American population, right? And we look at all these social systems, we point to, racism, right? But we do have to, in addition to understanding that there are institutional differences in terms of treatment, in terms of access that we have to fix, right? And that's a policy, structural, systemic level issue. We also have to consider the toll it takes. What does it do? What are the processes that are involved in the way that this takes shape on bodies? And I would say though too, and I didn't get a chance to look in the chat. I assume based on my conversations with Pilar that many of you, I should take a quick look here though too at this point, are, let me see here. Let's see what we're looking at for social workers, health advocates. I'm seeing folks who are in community health, seeing behavioral health folks, researchers. Okay. Let's see, different trainers, data science folks, nonprofit people, MSNs, MSRN, RNs. Okay. So what I would say though too is for all of us really considering again the different ways that racism takes the toll, right? um and I say this though too, I was thinking about this from a mental health perspective. um Oftentimes, and I would say probably for a mental health practitioner who does not experience racism, there may not be, and I would say even for folks of color, a really good understanding of the way that racism really harms people outside of the ways that access it blocks access. access. And that's important. And we have to acknowledge that. But what does it do to our psyche? What does it do to someone's self-esteem? What does it do to in terms of anger, in terms of guilt, right? All of these other factors, all of these other psychosocial ways that it can also affect our health. So when we talk about the biopsychosocial effects of racism, we're considering the interplay between the psychological, behavioral, and constitutional who this person is, right? How this person copes, this person's background as well, their history, and then sociodemographic factors. We have to also consider differential exposure to and coping responses. So the exposure can be, it can be vicarious, right? It could be watching or seeing police brutality on television or social media. It could be that someone had a direct experience with, say, for example, police brutality, right? There may be differences in terms of level of exposure, or they may be more similar than we think. Um, we also have to consider when we're talking about the biopsychosocial effects, the interventions and prevention strategies that may help to lessen the impact of racism. And this is really where folks come in who aren't part of this conversation in terms of the work that you do, either one, how that work can, how we could actually strategies and interventions to help prevent the impact or lessen the impact, as well as looking at systems to really stop racism. And over time, we have to consider the stress response and that influence on health outcomes. Also, perceptions of racism, usually the result of psychological and physiological stress. Okay. The perception piece refers to if someone is able to recognize it as such, or if they think that it's something else. We also have to note that racism may affect health even when it's not perceived, right? So some people may say that, well, it's not just that I have to maybe try harder, or maybe I'm not trying hard enough, right? And that is a concept that, oftentimes like this high effort coping in a public health term is referred to as a concept they call John Henryism, in terms of like feeling as though you have to work harder or you're not working hard enough, right? So sometimes it can be a little bit of an internalized kind of racism, thinking if I just do better, or if they just did better, right? This could actually work out differently, but it may not be racism, but there can still be health consequences to this. Um, Perceived racism is only one of several possible pathways. Um, so let's talk about some of the institutional factors. And then we'll come back to a specific case. I want to, Pilar, I just want to check on our time. We're finishing this section at 2:30, correct? Roughly 2:30, 2:40, maybe?
Yes.
Okay. So neighborhood and health. Let's talk about our neighborhood and how neighborhood impacts health outcome. Considering access, right? So we have to recognize that we talk about community and neighborhood, that much of our services are tied to our community and our neighborhood, whether it be healthcare institutions that we can access, whether it be the kinds of grocery stores that we can go to get food, if they have the kinds of foods that people need, good fruits, and vegetables, adequate supply, right? Are there dentist offices nearby? What about walkable spaces, right? There was an interesting study that came out maybe 2 years ago that looked at heat in urban areas, right? And high dense excuse me, highly densely populated areas. And we know, and the pattern is that they're hotter, right? And oftentimes it has to do with trees or lack of trees. We're seeing a decline in urban infrastructure. Again, parks, green spaces, trees, right? Things that people who are living in communities that have these things may, take for granted, that it's okay to get up after dinner. You can actually take a walk and feel safe, right? If you're living in a community where the neighborhood is kind of signaling that it's not safe to do that, or even for parents to say, well, my kids can't go outside and play, right? It does take a toll on our health in terms of what we're able to do in terms of leisure, in terms of other activities that can enhance our overall health. We also have to consider the age of housing, right? Older homes, we know, in housing stock, we can see lead paint, other asbestos. The overall infrastructure, may not be as sound, right? Um, and also there was a pattern in terms of economic status around neighborhoods, right? But that's also very much tied to resources that people have, tax base, things of that nature. Medical care is another way, right? So challenges that African Americans have with accessing medical care. So it could be literal access to a facility not being close enough or located in a neighborhood. And then, of course, there is health insurance, right? But then there's also a matter of not being treated with dignity and respect when people show up for care, whether it's with a practitioner in an ongoing relationship, and or if there is an emergency situation, or if it's a situation, the time of delivery. So we're seeing, patterns of bias in practitioners. This happens in mental health. This happens in substance use, abuse and treatment, right? We're seeing this, constantly, consistently in different levels and areas of care. So people of color are less likely to receive appropriate medical care, and this really feeds into, talking about breast cancer rates, for example, right? And I shared with you that although white women have higher rates of breast cancer, Black women die often from breast cancer, right? That really does, there are a number of issues. I mean, we have to speak to, diagnosis. Right, time of diagnosis. We have to even speak to the ability of equipment to be able to diagnose patients equitably, right? And what I'm referring to is, for example, um, mammograms, are recommended, right, for the diagnosis of breast cancer. But a mammogram may not be enough if someone has very dense breast, right? So someone may actually have to have a more of a diagnostic kind of mammogram that includes an ultrasound, and having a radiologist will, kind of take a closer look to make sure that there's not something there. And if something is there, go a little bit further, right? But it may actually require a patient advocating for that. And if practitioners are biased, they may not actively advocate for that for all patients. All right. Pharmacies, even access to pharmacology. It's noted that there are differences in terms of what pharmacies hold in certain communities as opposed to others, right? And this has been noted with the opioid epidemic, in terms of, access to pain medication, right? It's been going on for a long time in terms of low income African American, Latino communities not having adequate supply of pain medication. Now I know that this goes into another area in terms of opioid use, misuse, etc. However, no one should have to live with pain, right? So we're talking about pain management, and that also has not been for some time adequately appropriate and distributed appropriately across population groups based on race. I've mentioned treatment quite a bit. But even the assumption, and there's documented research on how physicians look at patients differently based on race. So this comes out in terms of the treatment, but even the thinking behind it, the attitudinal racism that I mentioned before. There was an interesting study that really pointed to that focused on physicians, how they viewed patients. And one of the questions was, if you see, they looked at Black patients and white patients of physicians, and physicians were asked how often you would see the Black patient or the white patient as a neighbor or a friend or a family member, right? More times than not. And this is consistent with both Black and white physicians. The white person was viewed as a friend, a family member, or a neighbor. The Black person was not. That really speaks to how, in the case of healthcare, providers may humanize white patients and dehumanize Black patients, or not see them as human or even deserving of appropriate care and treatment, or may not go that next, as far to make sure they're getting the care and treatment that they deserve and are seeking. We have to consider segregation and the environment as well in terms of housing stock once again in neighborhoods, but the close proximity of low income and brown neighborhoods to tags to toxic sites and other environmental hazards, right? So brown fields, we're talking about waste facilities. Okay. In addition to that, companies are more likely to engage in illegal dumping in low income communities. And this really speaks to a policy issue because they're not fined as high if they're dumping in low income communities of color as opposed to them dumping into a more prestigious community, right? Where they're less likely to do because their fines are much higher. Um, and the other piece of too, and I don't want to ignore this, is also in terms of the ability, we've seen this time and time again, Cancer Alley, where communities of color may not have the resources to rally against and stand up to big corporations because there are a lot of expensive legal fees, right? At the point that people are really trying to be compensated even, or um, to establish a formal complaint about some of these atrocities and illegal actions of companies when it comes to environmental racism. This is an image of the biopsychosocial effects of perceived racism, and I'm going to just kind of walk you through what's here. It's probably not as clear visually as I would like, but it starts with the environmental stimulus. That would be a form of racism. Okay, so the environmental stimulus refers to some form of racism, and it does consider other factors that shape how it's perceived. Okay, the idea behind the biopsychosocial effect of racism, and again, if this model focuses on the perception and perceived racism, is that there is some level of perception, and we noted though too, it doesn't have to be perceived for people to still deal with the adverse consequences. So under the exposure, there could be constitutional factors. Okay, so that has to do with more about that person, right? Maybe where they were raised, how they were raised, in terms of if a person is particularly resilient. I know people sometimes shriek hearing that word now. um Also other socio-demographic factors, right? Class, for example, or education, for example, psychological and other behavioral factors, right? In terms of, say, mental health status or someone's ability to cope, right? All those factors can be very much tied to perceptions. And based on the perception, or when we get to the perception, it would be a matter of whether or not it's perceived as racism, or if the perception is due to a different stressor, right? Or maybe there's no perception of racism or other stressor. And the middle circle here, the perception of different stressor, for example, it could be, well, maybe I was discriminated against because I'm a woman, right? Or maybe I was discriminated against because of the way that I speak, right? And not because of my race per se. Under the perception of racism and perception of different stressor, kind of takes a separate path, and that would be coping responses, right? And I just might want to make a note here. Coping, we could be talking about, healthy coping. We could be talking about maladaptive coping. Okay. In my research on substance use disorder, really looking at patterns between exposure to racism and maladaptive coping, and what variables kind of offset that. It could be, and literature speaks to this, so too, in terms of even things such as eating behavior, right? So when people are exposed to racism, maybe people are engaging in, maybe they're forgetting, or at this time they're not focused on the health enhancing behaviors, right? And they default to other behaviors that make them feel better immediately, right? Um, there could be other psychological and physiological stress responses. And then that leads to various health outcomes over time. All right. So that's a little bit about the biopsychosocial model. Here's another model that speaks to these pathways. So this model considers, I want to first start with, the social status, kind of go out of order here. And the social status, again, this model, it considers racism, right? But clearly it speaks to different levels of discrimination, but race is here. So we have the social statuses here. Socioeconomic class, again, we're looking at basically, or SES refers to socioeconomic status, but that's also proxy for class in sociology. Um, That could be level of education, how much money or wealth standing of an individual, depends on how the researcher measured it. It could be occupation, etc. Race, ethnicity, and then gender, age, marital status, right? Those are all the statuses considered in this particular model. And prior to the status, there's some basic causes here, and one being biological and geographical origins, okay, in terms of history and place, social political institutions as well, so policies, economic factors, and then also racism is listed here, the two, as an institutional and cultural element that shapes the experiences that people have around the social status that in turn lead to various paths that follow. So after we consider our social status here, there are some proximal pathways that are considered in this model, one being a cultural transmission. So it could be stigma or prejudice or stereotypes. And I want to lean into substance use um, once again, okay? Because when we think just like any other dimension of sociodemographics, um, it's not always just one thing, right? So when we are considering health outcomes, it could very well be um, they're talking about Black MSM, Black men who have sex with men. All right. So we have race, we have our sexual identity, and then we could also be talking about a substance use disorder, right? So someone who is also living with a substance use disorder, right? And maybe there's also an HIV infection, right? Or HIV status as well. So all of these things can happen collectively, right? And we see this, but attached to that, there could very well be stigma attached to it. And that stigma, and I want to say that in the case of stigma, because the stigma can be very specific, right? In terms of who's deserving and who's viewed as not deserving. And when this gets kind of layered, this creates a challenge for people in terms of how they're integrated and how they seek care, right? And then also, oftentimes for practitioners as well, how they may actually view people if they're not aware of their own biases. Um, Also, stress factors play a role under the proximal pathway. So, um, discrimination, other stressors, threat of stress. I'm going to also add to that threat of discrimination, right? Physical and chemical exposures, historical trauma, macro and micro racial stressors. Okay. This really speaks to a lot of the stress of racism, different SES opportunities as well, other societal resources such as housing, access to health insurance, other resources based on neighborhood structure, knowledge. Okay, awareness is also important. That could also be very much tied to education and how people actually respond when they're exposed. Okay, this goes back to the previous biopsychosocial when we're thinking about the Constitution, right? But it could also be resources that very well shape behavioral responses, right? What people have to their avail. So, if I get stressed out, one of my coping strategies is I need to go get a massage. Everyone's not able to go get a massage, right? If they're feeling a lot of stress. Maybe someone needs a therapist, but they don't have the insurance, or their insurance doesn't cover therapy, or they can't get to a therapist soon enough, right? Because the practitioners who they can see may be less, right? There may be less, a smaller pool of practitioners to choose from. So all of these factors can weigh in on how people respond. Psychological responses, this could be shaped by someone's racial identity, someone's self-esteem, or stereotype threat. And stereotype threat is really, again, the fear of being placed into a one what people the stereotype being placed on you, or fear of that, right? If I show up this way, people are going to assume, based on how I appear and how I look, that this is what's happening, right? So there could be some fear in that. And then we have these various health outcomes, whether it be morbidity, in terms of like the rates of various diseases, whether it be obesity, cancer, HIV, substance use disorder, and it goes on and on and on. Mortality, early death. Okay. And this again is really the inequity, all right? We're talking about higher rates of the diseases, higher rates, and in lower life expectancy at time of birth based on race. Okay. That's not a disparity. That's an inequity. A disparity would be different if we're talking about age, if we're talking about outcomes, for say, a 90-year-old, okay, and say, a 5-year-old. We're going to expect that someone at 90 is going to have less years of life left, right, than say a 5-year-old, right? But if we're looking at a bunch of 5-year-olds and we're seeing differences in terms of who's getting sick from what, and we see these patterns based around where people are living and based on race, those are injustices. Those are inequities. And we have to go back and look at those pathways and actively try to correct socially what's happening in those pathways. Disability, mental health, and then also there's room for positive health though too, because we have to talk about that part. Um, and oftentimes in this work, we study the adverse consequence and not the positive, right? And it's been noted though too, in terms of even studying to an extent the positive health outcomes and what's happening in terms of the positive health. We're probably going to see a lot of opposites, right? In terms of access issues, in terms of treatment and care, in terms of conversation, in terms of being able to speak to a provider as if they are your friend, right? Or a neighbor or a relative. Okay. I don't have too much time left, but what I will do in the time left, I do want to speak a little bit about some research that I engaged in a while back, because this is something that could very well get unnoticed in healthcare and for practitioners to not ignore. I was essentially, as it relates to how social factors tie in to health. And I'm using the case of racial profiling of police brutality on the health of Black boys. So this goes back to maybe about 9 years ago at this point. I interviewed several boys from New Haven, Connecticut, also Hartford County, and Bridgeport, and I had conversations with them about exposure. This would be um, um, different levels of exposure, really looking at national cases, right? So this would be more kind of a vicarious kind of thing, and then many of them witnessed the brutality via social media or on news, right? But how that exposure really affected them. So, this is just some background data on Black male health and life expectancy. I'll just read the first bullet just for the sake of time. So we're most of us are probably well aware in terms of a life expectancy for African American men, that African American men have some of the poorest life expectancy outcomes and the quality of life outcomes of any other racial ethnic group in this country, right? And we're seeing this across age groups, okay, and it's patterned for Black men. Um, Homicide is one of the top leading causes of death for Black men, and we're seeing increasing rates of suicide. I don't have that noted here, but I actually do have it here. Um, And so this really speaks to neighborhood, right? In terms of environment, in terms of other social systems that make Black men vulnerable to these outcomes. And then police brutality also becomes a serious risk factor. And I just have to say this here though too, that just because this study focused on boys, Black boys and men, it does not devalue the impending threat that police brutality and violence has on Black women, right? And I will also add to that, indigenous populations as well. Okay. I just want to make note of that because sometimes when I'm presenting this research, people have asked me, are you going to be looking at women and girls? Because these are also really important topics, right? Um, so police brutality, police killings, or I refer to them here as extrajudicial killings, and I use that language specifically because we're talking about law. When someone has on their uniform and their badge, right? It's no longer personally mediated at that point, right? They're representing the state, and they become they represent the state. So with that being said, it that we have to really there is the person can bring their own personal biases into that, but when the state does not address this, okay, we're talking about what becomes extrajudicial. Um, So, according to estimates, goes back to 2015, 49.7% of people killed by law enforcement were white. Okay. 28.3% were Black and 15.5% were Hispanic Latino. And this really speaks to population differences. And this is from 2015, however. And I'm sure now, there's so much more data. Um, I'm going to advance this. So when we talk about blacks who are killed by police, most people are unarmed, okay? They're more likely to be unarmed, and we're talking about younger populations. Um, and it's just noted here in this example that the extrajudicial killings aggravate what we're already seeing as excess mortality rates in African American populations, and it advances feelings of health outcomes around hopelessness. Okay, so this was a pilot study that I conducted some years ago, and it's called The Nation's Unprotected Children. And it was actually um, really kind of examining, what happened in the case of Mike Brown. In this study, I was interested in understanding how national cases affected the emotional health of Black boys, um, and really to understand how and if the stress from witnessing this level of racism in the form of police brutality affected boys and in which ways. Okay, I'm going to move quickly. So I'm going to share some of the findings. These are based in theme. This was actually a qualitative study. So I took detailed interviews with these boys. Um, so this theme here is that Black boys recognized that they were seen as a threat. Okay. So some of the things that they said were uh, that cops are misjudging or assuming that guys are wrong and bad. And it ends up whoever they are stopping is not the guy, not the person they should be going for. Another boy says they automatically see you as a threat because Mike Brown, police in the court hearing, said it approached me. It's like an N word thing. Not seeing Black boys and men as people. Okay. Another boy said every single Black guy doesn't sell drugs, isn't in a gang, does not do stereotypical things that media and society portrays us to be. And I just want to interpret this a little bit. We're speaking to how Black boys understand, based on the treatment and what's happening in society, how people who look like them are actually perceived. All right. And again, stereotype threat is there as well in terms of being, that being also assigned to them in terms of this a sense that the dehumanization being applied to them. So another piece that's really significant here is that there was fear of police, right? So they said that I'm fearful for my life. If I walk by a policeman or someone with authority, being a Black man in this country in general is just a threat by itself. I fear it could be me. If I might be innocent or just down the street from an accident, they assume I'm the guy. That's a fear. Just the fact that I could be killed or beaten down. Someone else says it could be me. I feel scared when I walk by a policeman or woman if I do something wrong. I think I can be concerned for kids who might dress a certain way and not because they want to, but because they have to. It's just how they have to dress, maybe because the environment they live in, they may have it a little harder than we have it because we're here. Another theme is that Black boys have to be careful. So there's this hypervigilance. Okay. So if I walk outside my house, I have to take my hood down. I remember my mother always telling me, like, if I go into a store to take my hood down, because when I walk in with a hood on, I'm seen in a certain way, I have to watch out. Um, so some of the things that they also said is that I have to be mindful who I hang out with. If anything bad is going on, I have to walk away because police might think that I'm involved. I have to watch out who I hang around. I was always taught that if there's anything going on or anything, I just have to walk away. If there's a fight or a shooting or anything or a robbery, I have to get out as soon as possible because police may think that I'm involved. Um, and then there's a pattern of just really getting home alive, right? The struggle to make sure that you're surviving. You're not protected by people who are hired to protect you. So if it comes to police officers, if they ask a question, you just answer them honestly. To me, you do whatever you can to get home. Whatever he tells you, do what the cop says. Once it's all over, go to my parents and tell them what happened instead of having a conflict with the police. So we see similar patterns of this, behavior in terms of assuming deference before the police, showing that you're polite. We know that this does not always work, right? But it's one of the strategies that the boys thought that, they were told to do this, they were not going to be confrontational with the hope that that would allow them to get home alive. Okay, so just some reflective remarks because I want to turn this over to discussion. This is a presentation where I don't come with all the answers for this presentation. I really come with really presenting this in such a way so that we can have some fruitful discussion so that you have some food for thought and that you're really thinking about the totality of issues that people who you're working with may be bringing to a situation, whether it be in a therapeutic engagement or even, a patient who you're seeking their health for a personal health matter, etc. So, as a society, it's important that we do track these differences. Right. And the consequences. We do live in a system that is racialized in many ways, right? So we do see these correlates in terms of health status with race. All right. And I do want to emphasize here that it's not because of race per se, right? It's the racism. And I want to say the difference of two because I didn't start with race being a social construction, that it's not biological, right? But I do want to make sure that that's clear, that we're not talking about biological difference based on race. We're talking about the experiences that people have based on their based on phenotypic characteristics, right? Um, so what we're talking about here are really attempts to fight for social justice in medical care and public health in the US overall. So we have to discuss ways in which being racialized and experiencing racism can affect health. So just some more conclusive remarks. So it's important that we understand the larger context in which good health or sickness exists, which includes acknowledging real barriers that people face, including racism, right? When they enter a hospital or clinic or a healthcare system. But I want to add to this as well. It's not just when people enter the system. Other social experiences that people are having, right, that people may bring into them when they are sick, right? And these other social concerns that we all need to be advocates for if we're truly concerned with the health of people who we're serving. So this does not require more, it does require more compassion from healthcare providers and also health administrators in terms of cultural competence, right? It also involves collaboration between health professionals and others outside of the health profession, urban planners, people in transportation, educators. And it requires education. Education is not the only factor, but it does require for people to have a full understanding and scope about what's happening for healthcare providers as well as for policymakers. And I would even push more, though, too, that health providers be more engaged in social determinants of health and health, the idea of health in all policies, right? So there are implications in health in education, right? Or there are implications for health, I should say, in education, implications for health clearly. If we're talking about criminal justice policy, right? Or housing policy, there are implications for health.